Oh, hello and good evening, everyone. Welcome to the 122nd Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And today's virtual seminar is sponsored by Yene Health. Yene Health is a femtech company, a pioneering organization focused on women's sexual and reproductive health. Yene Health is committed to improving healthcare services across Ethiopia through advocacy, education, and e-pharmacy services. So Blue Health Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Heno Tadela from Blue Health Ethiopia. Today, it's a pleasure to have Dr. Eliezer Haile here with us to have a presentation on pediatric pulmonary hypertension. Dr. Eliezer Haile is a senior pediatrician and a medical director at the Cardiac Center of Ethiopia. So, Doctor, the stage is on yours. You can begin.
Thank you so much, Blue Health, for giving me this opportunity. And I would like to say something about the Cardiac Heart Center, as I am from the National Heart Center, which is the only charity organization in Ethiopia, as you may know. And we deliver more than 600 cardiovascular service, catheterization, and intervention. And saying this, you could come and visit us anytime. And today update will be about pediatric pulmonary hypertension, which is one of the common complication of left-right shunt lesions, and as well isolated pulmonary arterial hypertension. So saying this, I will start with a brief introduction. We will have definition, epidemiology, pathogenesis, as well classification, especially the updated World Symposium on pulmonary hypertension classification, and the other functional classification like NIHA or New York Heart Failure classification. We will have that one. And clinical features, how patients present in the approach, the clinical investigation as well. We will see diagnostic investigations like ECG, echocardiography, the role of catheterization, as well as sometimes you may need even to biopsy to stage the pulmonary obstructive vascular disease. The other is management options, though we don't have the pharmacologic management except one. So we'll see that one in the prognosis as well as what we reference for this particular updates. So the objective of this presentation will be, know how to approach a patient with pulmonary hypertension, describe the pathophysiology, understand the mechanism of pulmonary hypertension. That helps for severity assessment, starting management, and anticipated complications based on the primary lesion, which results in pulmonary hypertension. So as an introduction, we have to know the disease characteristics. Elevated pulmonary arterial hypertension. What do you mean by that? And the other is what's the difference between pulmonary arterial pressure and right ventricle failure? As well, one depends on the other. When a patient has elevated pulmonary arterial pressure, which is against the RV pressure, the RV will be hypertrophied and felt. That moment we say right side heart failure. Otherwise, in children, pulmonary hypertension commonly it's associated with underlying congenital heart disease or lung disease like BPD. So those premature babies will have almost all pulmonary hypertension, which is not considered to be pathologic unless it's persistent. And the other pulmonary hypertension may be idiopathic, familial, and pulmonary hypertension commonly we may consider the other morbidities and mortalities when it is isolated idiopathic pulmonary arterial hypertension or other, like depending on the group 2, 3, 4, 5. So we'll see that one. Management of children with pulmonary hypertension requires a multidisciplinary team because it could be pharmacologic, sometimes related with systemic other illness like rheumatologic diseases, and it may be isolated to the cardiac, like left to right shunt lesions, which could be addressed by surgery. So once you address the left to right lesion, the pulmonary hypertension will be done. No need for management, except some group of patients post-operative may have persistent pulmonary hypertension. So the definition for pulmonary hypertension, it depends. Pulmonary hypertension includes pulmonary arterial hypertension and pulmonary obstructive vascular disease. But when we say generally pulmonary hypertension, it should be defined greater than 3 months because it should be persistent. As I have said previously, newborns will have right side high pressure, elevated pulmonary arterial pressure because the lungs are now mature and not receiving in utero as a functioning gas exchange machine. So the pulmonary arterial pressure will be high. But after newborn past 3 months of age, if the mean pulmonary arterial pressure is measured greater than 20 millimeter mercury at sea level, it's defined as elevated pulmonary hypertension. So when we say pulmonary arterial hypertension, it refers to as elevation of the pressure in the pulmonary arterial system greater than 20 millimeter mercury, or the vascular resistance measured in Wood's unit greater than 3. This is in the cath lab measurement. So with normal pulmonary venous pressure, if you find resistance or pressure measurement, like as put at 20 millimeter mercury or 3 Wood's unit, it's defined as pulmonary arterial hypertension, which is part of pulmonary hypertension. The other pulmonary arterial wedge pressure should be less than 50 millimeter mercury when you measure the vascular resistance. Pulmonary venous hypertension is the veins which are draining back to the left atrium if they have elevated pressure that is post-tricuspid or post-capillary. So elevation of the pressure in that system greater than 50 millimeter mercury is considered to be pulmonary venous hypertension. So we have here arterial hypertension and venous hypertension, even if it is pulmonary. So we have pulmonary arteries and pulmonary veins. Pulmonary veins which drain to the LA, left atrium, but the artery, the MPA, the main pulmonary artery, which receives blood from RV collected from the RA, from SBC and IVC. So it's different. You have to understand this, by the way. It's very important. So hemodynamic definition for pulmonary hypertension, one is precapillary. As I have said, precapillary and postcapillary, it's different. So the mean pulmonary arterial pressure measured greater than 20 millimeter mercury, which is classified into group 1, 3, 4, 5, which we will see later, and isolated postcapillary pulmonary hypertension greater than 20 millimeter mercury, the same, but the pulmonary arterial wedge pressure, if it is isolated postcapillary, should be greater than 50 millimeter mercury. Then the pulmonary vascular resistance, which is less than 3. You should, okay. So that's a point I want you to understand. When it is combined or precapillary and isolated postcapillary, that the management will be different and the classification is different. So you need to understand these things. Fetal pulmonary arterial pressure is similar to systemic pressure that I already mentioned. Newborn will have high pulmonary arterial pressure because in fetal life, they have right ventricle dominance, right? So the RV will be dominating the LV. Then at birth, almost hemodynamically equal. Then until 3 months, the LV will take over and the systemic pressure will be higher than the pulmonic pressure. So adult levels of pulmonary arterial pressure are archived by 2 to 3 months of age. That's what I try to mention in the early time. So the adult pulmonary arterial pressure will be achieved 2 to 3 months. The precise incidence and prevalence of pulmonary hypertension is not well studied and it's not known. I tried to find it in different literatures. And even the pulmonary arterial hypertension is different in geography, by the way, because when we host European missions and other, they don't look at our patients like the other groups because we are in high altitude. Oxygen has high effect on pulmonary vessels, which is vasodilator, and may not significantly affect post complication like pulmonary vascular obstructive disease, but it really affects the flow to the pulmonary system as it is vasodilator. Oxygen is vasodilator. So saying this, pulmonary hypertension occurs at any age, by the way, and the pediatric age group typically 7 to 10 years with different reasons, whether it is cardiac or pulmonary region. It's commonly found 7 to 10 years of age. This is textbooks. So female outnumber the number of males 1.7 to 1. The other is true incidence of pulmonary arterial hypertension related to CHD has not been established because in different literatures the prevalence of CHD worldwide it is almost 0.8%. But when you come to Africa, it can reach up to 12-15% reporters, especially sub-Saharan. So physiologic and physiology of pulmonary arterial pressure is, as you know, pressure is equals to force divided by area. The force depends on the mass of the blood and the acceleration of the blood. You understand me, right? So divided by area, the vascular space where it passes through. When the pulmonary vessels are narrow, the pulmonary arterial pressure will be elevated. But when it's wider, dilated, it will be lower. So when you take this physics, the decrease in cross-sectional area of the pulmonary vascular bed results in increased pulmonary arterial pressure, because what we said is pressure is equals to force divided by area. So the area is inversely related to pulmonary arterial pressure. When pulmonary arterial pressure increases, the cross-sectional area of the vessel will decrease. And the increase in pulmonary blood flow, the acceleration, is directly related to the increase in pulmonary arterial pressure. The increase in pulmonary venous pressure, commonly due to elevated left atrial pressure. The left atrium should receive the 4 pulmonary veins, but when it's not receiving easily, like mitral stenosis, it will have resistance, right? Elevated pressure. So it's directly related to the increase in pulmonary arterial, the backflow of blood from the lung to the MPA, main pulmonary artery. That's the relation between pressure, force, mass, acceleration, and cross-sectional area of the vascular beds. This is very important. When we come to the summary, the pathophysiology, there are 3 main factors which really determines the vascular resistance: the endothelin pathway, nitric oxide pathway, and prostacyclin pathway. So nitric oxide, as you know, it's a vasodilator. Even we use it for vasoreactivity test. And prostacyclin as well. It relates with that cyclic AMP. You can see here on the screen, I think. Here, the role of endothelin pathway, nitric oxide pathway, and prostacyclin. Here, as you can see, the nitric oxide, it relaxes. The prostacyclin as well, it relaxes. But when it's impaired, this pathway, both, they will result in vasoconstriction. The other is the smooth muscle cells. They depend on endothelin production. So these 3 mechanisms are the very important one for pharmacologic management of pulmonary hypertension. As you can see here, nitric oxide will be produced with prostaglandin I2 once the endothelin 1 produces endothelin. But if there is no production, there is no relaxation. You understand? So these three have main roles. The caliber of the small pulmonary arteries, as I said, the pathology classification here, you can see the active vasoconstriction, the anatomic change results in pulmonary vascular obstructive disease. It will get worse when there is anatomic change. So first, initially, the vessel look like this one. It is wide and it is circular, as you can see, normal, thin-walled. But when it comes to, grade 1, medial thickening will be there. The smooth muscles will hypertrophy here. Then the intima thickens, the smooth muscles will thicken and increase in size. The other, not only the intima media, the plexiform, it will form like the intima, the media, and the peripheral tissues. The adventitia will change to plexiform layer. Then it will be distorted, high pressure. This is pulmonary vascular obstructive disease, irreversible. Eisenmenger will be there if there is left to right shunt lesions. The main contributing factors in development of pulmonary hypertension is, one is developmental abnormalities, because, intrinsically, if there is a genetic problem, it will predispose for pulmonary hypertension. There are, 8 to 10 factors which contribute, like Down syndrome, those of patients with Williams syndrome, and even in utero, most of the syndromes which do not survive, they will have significant pulmonary hypertension. So external stimuli like alveolar hypoxia, as I have said, oxygen is vasodilator. In the absence of oxygen, there is vasoconstriction in the pulmonary system. So that will be contributing factor. And the intrinsic mechanism like congenital heart disease, atrioventricular valve lesions, and those of VST, AVST, they will have, high flow to the pulmonary system. As I have said, the mass of the blood is very important, directly related to pulmonary arterial hypertension. So toxins, drugs, infectious agents, even the portal hypertension, because, the venous return from IVC will increase. So the pulmonary hypertension is most likely related to portal hypertension. Lung diseases, as I have said, lungs are the one receiving LPA and RPA. The right pulmonary artery and left pulmonary artery are draining the main pulmonary artery from RV directly to the lungs. But if there is too much resistance in the lungs, there is no flow to the MPA, the main pulmonary artery. So there is high resistance. So greater than 3 Wits unit, this will result in pulmonary arterial hypertension. Lung disease and sickle cell disease, the same mechanism. Sickle cell disease, the RBCs will be heavy and the lungs will be even, crowded. So it will increase. One of the most important risk factors. Chronic thromboembolic diseases still affect the lungs, and systemic disease, molecular cellular mechanisms like BMPR4 gene mutation and molecular specific, endothelin gene mutation will result in high pulmonary arterial hypertension. So here you can see, the vasoactive factors, serotonin, angiotensin 2, thromboxane, and the vasoreactivity factors like this one. Even calcium has a role in signaling, as you know. So growth factors like, platelet growing factors and, endothelin growing factors and other BMPR mutation, metabolic dysfunctions. We don't test them commonly, but these deficiencies and inflammatory changes will result in vasoconstriction. So this vasoconstriction, together with vascular tone change, proliferation of different cells, result in vascular remodeling. Once it's remodeled and pulmonary vascular obstructive disease develop, the resistance will be high and even the apoptosis of cells will increase. So it results in pulmonary vascular obstructive disease, which results in irreversible pulmonary hypertension. The histologic change, sometimes we may need to do, biopsy to confirm what is the cause, specifically idiopathic pulmonary arterial hypertension. So here you can see there will be RV remodeling, right heart failure, then dysfunction in the PA circuits, and there will be fibrosis of, the vascular stiffening, smooth muscle hypertrophy, intima proliferation. Then there will be fibroblasts in the degeneration change, fibrosis, scarring, and there will be WBC infiltration and inflammation as well. It will constrict at last. So there will be decrease in nitric oxide because it is vasodilator. In the absence of nitric oxide, it will be constricted. Not only the nitric oxide, even the prostaglandin I2, it will decrease and results in vasoconstriction. The endothelins, which will proliferate and it will stiffen the vessel, by the way. So increases the pulmonary arterial hypertension. So one of the mechanisms we interrupt while we treat patients with pulmonary hypertension is increase nitric oxide, increase prostaglandin I2, and decrease endothelin 1. This is what we want to do with pharmacologic management. We'll come to that. So the normal vessel, as you can see, tunica externa, tunica media, and tunica intima. This is the anatomy, normal vascular wall. But when it is change, as you can see, there is a cascade of change. It results in RV remodeling and right side heart failure at last. So this is the updated World Symposium on Pulmonary Hypertension update. So the classification of pulmonary hypertension into 5 disease groups and categories. Here, I want you to give emphasis on congenital heart disease because which is the most common cause of pulmonary hypertension in Ethiopia, and as well in pediatrics. Almost most common cause is congenital, then lung disease is a second, like BPD. So group 1, idiopathic and heritable diseases associated with drug, toxin, associated with connective tissue disorders, and even infectious like HIV, HPV. And portal hypertension. Here you can see congenital heart disease, by the way, in group 1. Shunt lesions, which is shunt lesions, commonly VSD, SD, AVSD, and PD as well. So they will have pulmonary hypertension. It's commonly flow related. So once you manage the congenital heart disease, the pulmonary hypertension will be gone. But it should not asymptotize or it should not be bidirectional flow or severe pulmonary arterial hypertension because you have to do diagnostic cut or operability assessment before you do the surgery. So other infectious is schistosomiasis, which is common in the eastern part of Ethiopia. And the other is pulmonary arterial hypertension with features of venous, capillary, this is vascular obstructive disease, and capillary hemangiomas, commonly involvement, and the persistent pulmonary hypertension of the newborn as well. So, okay. So the other group I want you to give emphasis is group 2. This is with preserved ejection fraction, with reduced or mild reduced ejection fraction, and you can take this one as left side heart diseases, because valvular heart disease like MS or aortic stenosis could result in pulmonary hypertension. Because the backflow, as I have said, LA will have high pressure, the pulmonary venous system will have high pressure, then the lungs will be highly vascular resistance, then the pulmonary systems will have high pressure. So congenital acquired, here again we see congenital acquired diseases like cardiovascular condition, post-capillary pulmonary hypertension, specifically pulmonary vein stenosis, triatum, aortic stenosis, MS, coarctation of aorta, as I have said. These are the very important one, left side congenital heart disease. That is a very important one. This one is shunt lesions, the left side congenital heart diseases. So group 3, commonly lung diseases, whether it's obstructive and other, you can take a look at and you can revise this one, and more of related to lung disease. So the other is group 4, chronic thromboembolic, like the thrombovenous diseases could result like this. And as well here, you can see group 5 hematologic disorder, systemic metabolic disorder, complex congenital heart diseases, segmental pulmonary hypertension. You know, these most of them are not classified in the previous times, or it is unclassified, group 5 in the previous time. But after 2018, six's World Symposium on Pulmonary Hypertension, they already classified like this one. So I think you will revise this one. Saying this, let's come to the different subgroups of pulmonary hypertension in CHD, congenital heart disease associated pulmonary hypertension. This classification is taken from American Heart Association, and this classification is depend on the clinical and hemodynamic profiles of the congenital heart disease lesions. And one is those Eisenmenger syndrome, those unrepaired moderate to large shunt defects. This is the most common one. You will see it in the outpatient department. Pulmonary arterial hypertension with coincidental CHD. Patients could have idiopathic pulmonary arterial hypertension with coincidental non-symptomatic CHD, and as well persistent or recurrent pulmonary arterial hypertension after surgical repair. You know, once you repair VSD or ASD or like PDA or AVSD, you could have persistent or recurrent pulmonary arterial hypertension post-surgical. That's classified as group 4. So this is very important class. You can see it right here, by the way. This is taken from American Heart Association and the group 1 pulmonary arterial hypertension with Eisenmenger syndrome. You can see it. And here, group 5, unclear and multifactorial mechanism. Well, that's what we revised. And here you can see group 2, left heart disease. I already summarized in the table. Pulmonary arterial obstructive disease. This is almost lung diseases. You can see the picture. You see here, left side heart disease, lung disease. Here is multifactorial group 5. Here it is idiopathic, intrinsic to the pulmonary arterial itself, by the way. So this is a classification for pulmonary hypertension in congenital heart disease. Saying this, let's come to specific to Down syndrome, because it is the most common congenital, syndrome associated to be found with congenital heart disease. Almost 50% of children with Down syndrome will have congenital heart disease, from which 39–40% will be atrioventricular canal defect. So pulmonary hypertension in Down syndrome is not fit to classify in a single classification. In the absence of CHD, it's grouped into 3 because of ventilation and lung issues. They will have recurrent chest infection, upper airway obstruction, obstructive sleep apnea, recurrent aspiration, and they are hypoventilated because of hypothyroidism and weak muscles. They are prone to have rickets, bone diseases. So they will have group 3 classification when there is no CHD, the 50% type. When there is CHD, they should be classified into group 1 or group 2, as you can see. If it is AVSD, it is shunt lesion, right? So it will be group 1. This is very important for your clinical management, by the way. That's why I'm taking much time on this one. So group 2, congenital obstructive lesions like congenital AS, PAS, or MS. So most of the left lesions are very important. So the mechanism is different from the others, and one suggested one is lung hypoplasia, and 3 anti-angiogenic or vascular endothelial growth factor gene are identified in chromosome 21. And you can just review them, but I try to mention them here. Endostatin and regulatory of calcineurin, RCAN1, and B amyloid peptide. These are recent studies, by the way. These are the anti-vascular growth endothelial factors. So these genes are specifically related to chromosome 21, trisomy 21. So this results in decreased vascular and distal airspace growth, increased risk of pulmonary hypertension, increased susceptibility for environmental stimuli. Saying this, Down syndrome specifically, you should address the lesion first, by the way. You should not try to pharmacologically manage, but you can use more of generous diuresis if it is AVST, which is the most congenital heart disease. So based on natural history of underlying etiology, it could be classified into transient and persistent or progressive. Most of time, it is if it is related with shunt lesions, unless you address the shunt lesions, it will be progressive pulmonary hypertension. But those of newborns at birth, if echocardiography done and diagnosed to have pulmonary hypertension, you should wait to declare it is actually permanent or persistent pulmonary hypertension, because it should be defined after 3 months of age. This is a WHO functional classification. This is like, New York Heart Association, like, those are patients with idiopathic pulmonary arterial hypertension, you could classify them clinical if they have like limitations with physical activity or not. So without limitation, you could classify them one. With limitation, you can classify it like, group 2, and the other group 3 with marked limitation, and you can classify them group 4 if unable to carry on any physical activity without symptoms. So this is very important. So common pulmonary hypertension in children, the most common one is related with CHD. So most common in pediatrics, almost 40-55%. The second is respiratory disorders, and the idiopathic one or familial idiopathic and heritable one, 10-50%. This 3 is very important. Pulmonary hypertension associated with chronic lung disease like BPD in premature infants have a great contribution for the second group of patients, those with chronic respiratory disorder. So only small minorities with CHD develop clinically significant pulmonary hypertension, but those above 3 months should be diagnosed. So 2 broad categories of CHD that can cause pulmonary hypertension include shunting lesions, left heart disease associated with elevated left atrial pressure. This is very important. Left heart disease, shunting lesions, and associated with elevated left atrial pressure, it's very important. So the clinical feature, the presentation of pulmonary hypertension varies considerably based on age of the patient, presence of or absence of medical conditions, severity of pulmonary hypertension. RV function is very important. So whenever we evaluate a patient with pulmonary hypertension or suspected of pulmonary hypertension, we have to start with history, as we always do. The most important and the earliest complaint they have is easy fatigability, and sometimes exertional dyspnea will be associated. So fatigue, syncope, sometimes if it is very high one, they will tell you palpitation, cyanosis, failure to thrive, cough, and chest pain is very important one. Heart failure is rare because at last patients will fail. They will try, the RV will try its best before it fails. So RV failure, the most common cause is left side heart failure, but RV could fail because of pulmonary hypertension, even if it's idiopathic. So the degree of symptom depends on that part on how well the RV adapts. So if the RV is good, adaptable, so that will be good, but if it's not adapting, it will be bad. So increased pressure load and like that one. So physical examination may be unremarkable with modest pulmonary arterial pressure, tendon neck veins with RV dilation, left parasternal hips. These are the physical findings you most commonly find. S2 narrowing split, because it is high pressure, it will take more time to flow. So that's why you hear S2 narrowing split. Systolic murmur of tricuspid regurgitation, because during systolic you will hear much flow, and the diastolic murmurs as well with severely elevated pulmonary vascular pressure. So you should look for hepatomegaly, peripheral edema, indicative of right side heart failure or RV dysfunction, because the RV is the one receiving the SVC and the IVC. So whenever there is congestion, hepatomegaly and peripheral edema is the sign. So you have to look for that one. Pulmonary hypertension with CHD clinical feature depends on specific defects, types of repair, and palliation. So those CHD unrepaired cardiac shunt lesions, cyanosis, and polycythemia will be there. And cardiopulmonary palliation, patients with single ventricular heart disease, like hypoplastic left heart disease, and the others like Fontan, bidirectional Glenn palliations. This should be addressed and followed. So they could have poor exercise tolerance, peripheral edema, pleural effusion, so other like protein-losing nephropathy. Diagnostic investigation, commonly we do chest X-ray, though it could be normal, but you can see the dilation of the MPA. When it is moderate to severe, you will see dilated main pulmonary. You can see the arrow right here, dilated main pulmonary artery. So there will be cardiomegaly, the RV try to fight against, but you may not see the RV, but the left ventricle will be elevated. You can see it. You can see it here. That's a sign with pulmonary hypertension, moderate to severe. So the ECG, commonly it will be abnormal, most commonly, but not always. So the characteristic finding is RV hypertrophy and RV strain. You can see it on ST waves and specifically on the inferior lips. And upright T wave in V1 is indicative of RV hypertrophy from 7 days to 7 years, by the way. So whenever you see T wave on V1, upright, it shouldn't be upright, by the way. So if it is upright, there is RV hypertrophy in this specific case. Less commonly, right atrial enlargement could be there. It's non-specific, so you cannot say this is because of that. So some studies have suggested that specificity could be 69%, positive predictive value of 67. Low, by the way. So we have other modality to detect. So ECG is not the best one. So you can see here, ECG in a young child. Here you can see the P wave. So right atrial enlargement, the P wave, it's greater than 3 boxes. So here, right ventricle hypertrophy and right ward axis deviation. So these things are the one to find on pulmonary hypertension. So the investigation modalities, though we don't commonly use, BNP and the terminal pro BNP will be there. So useful tool assess mortality risk, progression of the disease, and response for therapy as well. Recently, usefulness of BNP and terminal pro BNP is very important. So BNP correlates positively with the functional status of children with pulmonary arterial hypertension. The value above 130 picogram per ml are associated with increased risk of death, needs transplantation. The last management of pulmonary vascular obstructive disease is transplantation of heart lung, let alone not only the heart or the lung should be transplanted. BNP above 180 picogram per ml decreases survival. So that's very important to understand. Elevated BNP level does not distinguish between left and RV failure. So echocardiography, most helpful to test, this is very important. Even you can detect, congenital heart diseases. So it will provide you information to the, details of structural cardiac lesions, estimation of RV pressure, RV systolic function can be, quantitatively assessed with echocardiogram, as can RV free wall thickness, cavity size, although MRI more accurately measures variables. So assessment of valve regurgitation, tricuspid, and less commonly pulmonary valve regurgitation. Very important assessment. The tricuspid valve is the very important one because the RV, when it is pressured, there will be regurgitation of the tricuspid valve. So there are specific factors which influences echocardiographic assessment of pulmonary arterial pressure. One is technical factor, the other right ventricle size and dilation and its dysfunction, and the other is ventricular-arterial coupling and left side heart diseases if there is associated one, and rhythm disturbance, right atrium size and dysfunction, tricuspid valve, regurgitation is the factors which influence. And as well, individual and systemic factor, you can see them, age, body mass index, like obese individuals, it will be difficult, and athleticism, volume state, preload, if there is too much volume given for a patient, there will be a right side overload. So it will affect echocardiographic assessment of pulmonary arterial pressure. So miscellaneous like liver diseases, it will affect the venous return to the RV side. So the gold standard for diagnosis of pulmonary hypertension is cardiac catheterization. So it's not always necessary to do, initially, but it is the gold standard. It's unreplaceable. So indications to do commonly cardiac catheterization. One is initiation of targeted pulmonary hypertension therapy with certain exceptions. Those patients who require pharmacologic management, if you want to target the pulmonary hypertension level, you might need to cardiac catheterize. So it's one of the indications. When non-invasive test is inadequate or non-diagnostic, you have to say this is pulmonary hypertension. So if you want to say that, this is the gold standard. Follow-up of a patient with targeted therapy. Once you start calcium channel blockers, you might need to measure it again. So target, in order to see whether it's in the target or not, you may have to do cardiac catheterization. The other is operability assessment. This sit-bone criteria. You have to assess patients in the first year of life, especially if you don't manage them, operability will be questionable. Systemic to pulmonary shunting lesions needs to be assessed with diagnostic cut prior to going to surgery. Patients undergoing evaluation for heart or heart-lung transplant. It's very important to have cardiac catheterization. You have to assess the vessels. So that's very important. Cath lab information provide more accurate measurements of pulmonary arterial pressure. You can provide additional hemodynamic measurement like cardiac output, arterial pressure, pulmonary capillary wedge pressure. You can have vasoreactivity test. You can just see with cardiac laboratory test like cardiac catheterization. It could be even therapeutic sometime, by the way. So allows measurement of flow through shunt lesions. Intervention can be performed through shunt lesions. Device closure like atrial septal defect, coiling of orthopulmonary collapse. You can, demonstrate abnormal shape and distribution of pulmonary arteries. The branching pulmonary arteries may need to be evaluated prior to surgery. So cath lab will give you the information you need. When we come to acute vasoreactivity test, this is one of the very important topic because recently, administration of short-acting vasodilators, typically nitric oxide, will tell you the reversibility of pulmonary hypertension. Once patient is diagnosed with pulmonary hypertension, you have to make sure its reactivity. So Pediatric Task Force of 2018, 6th World Symposium Pulmonary Hypertension, they defined reactivity if there is decrease in mean pulmonary arterial pressure by at least 10 millimeter mercury. So a value of less than 40 millimeter mercury with no decrease in cardiac output. This is the sit-bone criteria. There should not be cardiac output decrease from RV or LV. So at least there should be a drop of 10 millimeter mercury, less than 40 millimeter mercury. So this is reactivity. So abnormal criteria define reactivity greater than or equal to 20% decrease in mean pulmonary arterial pressure. This is defined by systemic to pulmonary vascular resistance, unchanged or increased cardiac index. So this is very important to start them on calcium channel block. The other ancillary test we could have is cardiac MRI, but you can more accurately quantify the RV size, ejection fraction. Commonly, we don't do it. And the RV size and ejection fraction, if it is doubtful by echocardiography, you may have to do it with cardiac MRI. So the need for sedation, always there, but sedation should not affect the hemodynamic because, once you depress the hemodynamic, you may not get what you want on the hemodynamics of the heart assessment. So chest CT scan, sometime, but not, we decide with the collaterals and you want to see parenchyma of the lung because, the group 2 and the group 3, most of the time they are manageable. So if you have to do it, and if you have no cardiac explanation for pulmonary hypertension, if you want to see the parenchyma of the lung, you have to do chest CT. That's very important. But sometimes chest CT may not, diagnose pulmonary veno-occlusive disease, which is a group 4-1. So you have to specifically diagnose them, with a diagnostic cut. That is the gold standard, as we have discussed. The other tests we can use is pulmonary function test, 6-minute walk test, polysomnography, like obstructive sleep apnea related pulmonary hypertension, genetic tests, lung biopsy, and other, like, if it is infectious related, you have to do it. If you suspect endocrinology, like thyroid function test, you may have to do it. And if you suspect coagulopathy, you have to do it. So these investigations depend on your clinical assessment of the patient. Let's summarize the diagnostic approach of pulmonary hypertension. Here you can see a patient presented with signs symptom. Okay, you can see once patient present with eye symptom, clinical signs, and if you suspect a genetic syndrome, you have to go for echocardiogram, ECG, chest X-ray. That's a workup first you do always. Then consider most common pulmonary hypertensions. The most common one, as we have discussed, is congenital heart disease, specifically shunt lesions. They take most of 50% almost. So the other 20 to 30% lung diseases, you may need to do pulmonary function test for that one, or chest CT. So this is the algorithm you should follow. No sign of severe pulmonary hypertension or RV dysfunction, treat underlying lung disease, then it will resolve. But if there is diagnosis of lung disease confirmed, you have to go for sign of moderate to severe pulmonary hypertension or RV dysfunction assessment. If it is there, refer to pediatric pulmonary hypertension expert or a cardiologist. Pediatric cardiologist is a good one. So treat underlying lung disease or refer to pediatric pulmonary hypertension treatment center, like most of the tertiary hospitals will follow patients, by the way. Perform ventilation to the pulmonary to systemic ratio scan. You have to do it. Then if there is mismatch, you can do other investigations, chest CT angiography, selected pulmonary artery angiography with referral to the experts. They have to see it, especially the chest side radiographer. Radiologist should be communicated, because it could be subtle sometimes. The other is, once you perform, if there is mismatch between the pulmonary and the systemic scan, you can do cardiac catheterization at pediatric center with vasoreactivity test with mean pulmonary arterial pressure greater than 20 millimeter mercury, or pulmonary arterial wedge pressure less than or equal to 15 millimeter mercury, or the vascular resistance index greater than 3 Wood's units per meter square. So you should improve this assessment. Consider other causes once you roll out. After you investigate it thoroughly, you might end up idiopathic pulmonary arterial hypertension, where you can start pharmacology. So additional diagnostic testing, you have to do, the serologic markers, lab tests, liver function, liver ultrasound, and other like cardiac MRI and blah blah things. Sometimes you may need to do genetic tests, like we have mentioned BMPR, prostacyclin, or endothelin gene mutations could result in pulmonary hypertension. Let's come to the management. There is not much to say, but we have to treat underlying cause. Don't forget, pulmonary hypertension, it could be primary or secondary in the previous classification, but this case we don't say like that. So pulmonary hypertension is grouped into 5, as we have discussed. So we will treat underlying cause when there is a specific cause. But the other, we could have supportive medical therapy if it is like idiopathic one. Target pulmonary hypertension therapy is the main, recently updated. So treat the underlying cause. If it is a cause, if ST related or VSD related, you have to close the shunt lesion most results in resolution, but some cases may persist. In this case, once you close the congenital heart disease, if they have persistent pulmonary hypertension, you can start them on pharmacology management. Post-operative, not pre-op. Do not start patients with shunt lesion with pulmonary hypertension, as it is flow related, on sildenafil or other management, by the way, except diuretic. Left heart obstructive disease like PMBC, surgical correction, as we have discussed previously. This left heart obstructive disease, the most common one in Ethiopia is mitral stenosis related to rheumatic heart disease. So you have to do percutaneous mitral balloon coligiotomy, and you do surgical correction if it needs mitral valve replacement. This improves most of time and resolve after correction. Hypoxic lung disease, you have to provide oxygen because it's vasodilator, and then treat aggressively the lung disease. Then ventilator support may be needed till you manage the lung disease. Once the lung disease resolves, the resistance will drop, so the main pulmonary artery pressure will drop as well. It depends on confounding factors. Sometimes the lung fibrosis will result in persistent pulmonary hypertension. By the way, pulmonary tuberculosis is not a common cause, but you should take it into consideration because we have high burden of pulmonary tuberculosis. In literatures, you may find it's not that much common cause, but in Russia, India, and Africa, Sub-Sahara, it's common cause. So pulmonary hypertension exacerbated by obstructive sleep apnea, commonly with syndrome like Down. You have to supplement nighttime oxygen, ventilator support. If you have to do adenotonsillar, tonsillectomy should be done. 88 patients, that's related with obstructive sleep apnea, resulting in recurrent chest infection and directly results in pulmonary hypertension. So the other is pulmonary hypertension caused by thromboembolism. Anticoagulation will be the treatment, the management. So treat the underlying cause. This is very important. When we come to supportive medical therapy, conventional, you have to give oxygen. Do not forget, oxygen is pulmonary vasodilator and systemic vasoconstrictor. So it's very important for the pulmonary system. It will dilate and the flow increases. Diuretics, be cautious, by the way. Diuretics, do not be generous to give for a patient with pulmonary hypertension because the RV is struggling to pass through high pressure, which is MPA, pulmonary arterial pressure. So if you are going to diuretics the patient, the venous return will be low. So the RV will have small amount of volume, which tries to inject against resistance. So you have to be cautious when you diurete a patient with pulmonary hypertension. And the digoxin for the RV failure and anticoagulation is very important. So when we come to the targeted pulmonary hypertension therapy, sometimes referred to as pulmonary vasodilator therapy, we commonly use calcium channel blocker like nifedipine, amlodipine, but not verapamil is not approved for pediatrics. And phosphodiesterase inhibitor, the most common one we use is sildenafil. We use sildenafil right and left 1 to 3 milligram. We start TID based, and we will increase sometime based on response. So you have to be cautious. You do not start sildenafil shunt lesions pre-op, only post-op. So endothelin receptor antagonist like bosentan, which is not available in Ethiopia as far as I know, but we have sildenafil and tadalafil. Tadalafil is not approved less than 3 years of age in subliterature, less than sometime 5 years of age, but it's better to avoid. But you can use sildenafil. And the other is prostacyclin analogs, as we have discussed previously. Epoprostenol, I have seen it once, but I never use it, and I have never seen my seniors using in the outpatient department. But it's in literatures, it's very good and recommended. Even sometimes you have to combine them, these drugs, to treat targeted pulmonary hypertension. So when we select a patient to start on targeted pulmonary hypertension treatment, we have to be cautious. Here, the most important factor to decide is initiation of targeted pulmonary hypertension is the type of pulmonary hypertension, severity, degree of symptom, RV function. When we say, commonly we use sildenafil, the groups which will be benefit is one, WHO functional classification 2, those having, at least limitations on physical activity, class 2, 3, and 4. Moderate limitation. We start them, the functional limitation of the patient. And the other is severe pulmonary hypertension who lack apparent symptoms, but it's difficult to elicit symptoms, sometimes. So you may have to use it. Severe pulmonary hypertension, you have to use it. The use of targeted therapy in pediatric group 2 patients are lacking. You have to use a group 1 and group 3 well studied. So the other, based on the observational data, use of targeted therapy may be useful in selected pediatric patients like BPD, congenital diaphragmatic hernia. You can use it in patients with BPD as well as congenital diaphragmatic hernia, lung diseases, I mean. Other types of pulmonary hypertension, group 4 and 5, are rare in children. Targeted pulmonary hypertension therapy used on a case-by-case basis, It depends on a specific case, and it needs, team discussion sometimes to start targeted therapy on them, or catheterization evaluation may be mandatory. So patient evaluation for targeted therapy, always you have to take history, physical examination, chest x-rays, echo, cardiac catheterization is very important, and the acute vasoreactivity test should be done to start with calcium channel blockers. So disease severity determined by the degree of symptom and functional class, as well as echocardiographic and CAD assessment. Agent choice, the choice of initial agent of treatment for pulmonary hypertension is based on, in large part, the very important factor is AVT. AVT is acute vasoreactivity test. Unless there is a decrement less than 10 millimeter mercury, less than 40 millimeter mercury measurement of pulmonary arterial pressure with no decrement in cardiac output, you cannot initiate, because the calcium channel blockers will affect the patient hemodynamic. So you have to assess severity of the disease, availability of the your drug as well, and cost also influences the decision making, because they have to continue the medication for long duration to see the outcome. So reactivity, you can do, I have already said, responded about 10 to 40% of pediatric patients will respond for this targeted therapy. So calcium channel blocker should not be used in a patient with depressed RV function. The RV function should be assessed with echocardiograph and even sometime MRI. The RV size should be, assessed to start calcium channel blocker. Otherwise, if there is RV dysfunction, you should not start on calcium. That's the contraindication. You have to see the echo report. If there is right side heart failure with RV dysfunction, should not start on calcium channel blocker. So verapamil should not be used because it's a minimum pulmonary vasodilator and a negative inotropic agent. As I have said, you have diltiazem. If you have it, you can use it. Otherwise, not verapamil. Patients with reactivity, like responders, usually show a long-term fall in pulmonary arterial pressure with calcium channel blocker. So it's well studied. Acute vasoreactivity test, a patient is reactive, you can start on calcium channel blockers. Not used because not beneficial in these patients. Like alternative agents, you have to use phosphodiesterase inhibitors like sildenafil. Those patients non-reactive, you shouldn't use calcium channel blocker. So you can use alternative like phosphodiesterase inhibitors, sildenafil. Commonly we use it, and you can use endothelial releasing analogs and bosentan and prostacyclin analogs. So this is very important. Those patients, the choice of initial agent depends on the availability of the drug as well. What we have in Ethiopia is phosphodiesterase inhibitor, sildenafil. So we can use that one orally. You have to be watchful for the side effects, most of them. So you have to be watchful. So high risk, you can try with IV and subcutaneous prostanoids. but otherwise no need. So here is the summary. You will assess the severity and classify low risk and high risk. So here are the assessment: clinical evidence of RV failure, progression of symptom, WHO functional classification, draws, syncope, BNP, and anti-prob BNP. You should assess 6 minutes walk test. You have to do these things. Those above 60 years of age, you will test this one. And echocardiography, hemodynamic measurement by cardiac catheterization. This is the algorithm you can follow, and you can start them on treatment. I don't think, except sildenafil, most of the drugs are available. So we'll discuss more on sildenafil. So, calcium channel blocker, as I have said, the mechanism is they will relax the vascular smooth muscles, possibly reduce pathologic growth of pulmonary vessels. And the other is calcium channel blocker are used in a patient who are said to be responded for vasoreactivity test. Should not be used in depressed RV. That's an absolute contraindication. And long-acting forms of calcium, they are very preferred. In the Philippines is available, amlodipine is available. Commonly amlodipine is, it has side effect like edema. So they could have dependent pedal edema. So you should tell them before you start them. So verapamil should not be used, as I have said in the previous slides, and you should use deltiazem. So side effects of calcium channel blocker, hypertension and bradycardia is the most common. So the RV will be depressed if you give them with RV dysfunction. Phosphodiesterase 5 inhibitor, the very important one, which is available is sildenafil. It has been studied in pediatrics as well as adult, but tadalafil is studied in the adults only. But literature say less than 5 years, above 5 years. So don't use tadalafil. You can use sildenafil. It's available in Ethiopia, but it's sometimes 50 milligrams, so it's difficult to break it. And 100 milligrams. You can have sometime 25 milligram, when patients are operated abroad. So you can give it orally or IV. Those low risk, you can give it orally. Those high risk, you can give intravenous. So these drugs cause pulmonary vasodilator, may inhibit pathological pulmonary vascular remodeling by reducing the breakdown of cyclic guanosine monophosphate. Cyclic GMP is very important for smooth muscles to release nitric oxide, which is vasodilator. And not only the nitric oxide, the cyclic GMP accumulation results in activation of guanyl cyclase and other leading increased level of cyclic guanosine monophosphate signals molecular relaxation of the smooth muscles in the blood vessel. So that's very important. The other is, it inhibits the breakdown of cyclic GMP so that it will result in relaxation and dilation of the main pulmonary artery. So the pulmonary hypertension will drop. Sildenafil again, it's favorable effect of sildenafil in please take a note here. Idiopathic pulmonary arterial hypertension associated with cardiothromboembolism diseases and congenital heart disease post-operative. It's very important. You have to use it. Favorable effect of sildenafil. It's well studied. So the maximum serum concentration reach in 1 to 2 hours or half hour sometime. Improve exercise capacity, hemodynamic parameters, and they function well. The functional classification, the limitations with the daily activity will improve after 3 months. So you should give it at least 3 months before you reassess your patient. Patients will tell you after 1 month, I'm not improving, but you should tell them they have to take it for at least 3 months to have an improved WHO functional classification. So this is very important. Please take a look at it. Favorable effect of sildenafil is in patients with idiopathic pulmonary arterial hypertension and pulmonary arterial hypertension associated with chronic thromboembolic diseases, and CHD post-operative. So those telangiectatic pulmonary hypertensions. Those and side effects, commonly we initiate with 0.25 milligram per kg, and every 6 hours, or you can give 0.5 milligram per kg per dose, TID, and you can titrate. So you can maximum go on some literatures 3 milligram per kg per day, but you can escalate up to 5, 6. 6 is the maximum what I have seen. So you may consider low initiation. There are articles which say low dose versus high dose. Consider lower initiation like 0.25 milligram per kg per dose every 8 hours. Then for critically ill patients receiving concomitant vasoactive agent, especially less than 4 months of age. Those, are very important. Vasoreactivity is very important, and vasoactive agents, if concomitantly administered, you have to be cautious. Children and adolescents less than 8 years of age, you can give, like 10 milligrams 3 times daily, because low dose has no benefit. Recent studies say low dose has no benefit. We give 10 milligrams 3 times daily, those less than 20 kg, and 20 to 45, you can give 20 milligrams 3 times daily, but you have to be cautious to measure their blood pressure, check their, complications related with hearing loss or priapism. So that's very important. Sometimes they could have flushing, diarrhea, or dyspeptic symptoms. So you have to be cautious and follow these symptoms. So this is one of meta-analysis on randomized control trial. If you can just take a look at on the last statement, conclusion, sildenafil therapy reduces mortality of pulmonary arterial hypertension patients, but its effect on hemodynamic outcome and other clinical outcome is still not clear. This article concludes sildenafil has mortality benefit. When it comes to this one, in this, one of the retrospective study done, and it says, with pulmonary hypertension with sildenafil at a single institution, it's for about, 11 years they have studied, and they concluded, WHO group 1 and 3 pulmonary hypertension, low dose sildenafil, those idiopathic pulmonary hypertension, congenital heart disease with, shunt lesions, the previous WHO classification, this one, and group 3 pulmonary hypertension, low dose sildenafil was well tolerated, as you can see. So it's very important to consider these articles because, sometimes they may not be incorporated into textbooks. So let's summarize with idiopathic pulmonary arterial hypertension and heritable pulmonary arterial hypertension. When we do not identify underlying cause, we call it idiopathic, or it could be heritable. So there could be, management options still. You have to do vasoreactivity test. You have to do, general assessment and follow, manage RV failure with diuretic, oxygen, anticoagulant, and digoxin. Then if vasoreactivity test is positive, you can start on calcium channel blocker. If improved, you can sustain with reactivity, but not improved, you will try at least for 3 to 6 months, and you may, give options, oral inhaled prostacyclin, though it's not available in Ethiopia, you can start. But if vasoreactivity is negative, still you can classify low risk and high risk based on the clinical parameters, echocardiography, CAT assessment. Then you can manage with a postenoid, or you can start with endothelial receptor antagonists. So reassessment always needed, but there are the surgical options you can manage. Atrial septostomy or POTS shunts, you can shunt, divert the flow from MP. So, last result is lung transplant. So I think endothelial receptor antagonists we have discussed, bosentan, but they are not available, and they block action of endothelin 1. So which is potent endogenous vasoconstrictor. Once you block it, then there is no more progress. Some bosentan and masentan, they are non-selective. Abrasentan is antagonist of endothelin receptor A. It's selective. So bosentan is FDA approved for pediatrics greater than 3 years of age. Otherwise, the others are not approved. So prostacyclin, you can use endogenous signaling molecule. It works on vascular endothelium and potent dilator of pulmonary and systemic blood vessels. So promoting prostacyclins is very important. Inhibition of inflammation, smooth muscle cell proliferation, and platelet aggregation is very important. So pulmonary hypertension therapy, prostanoids may be administered through IV, but it's not available still in Ethiopia. So acute pulmonary hypertension crisis commonly it's related with sudden elevation of pulmonary pressure, especially when you close shunt lesions or when there is patient undergoing with critical stenotic lesions in the operation theater. So this is very important. You have to be cautious, especially surgery, anesthesia with an acute lung disease. They could decompensate. So you have to be cautious with acute pulmonary hypertensive crisis. The very important management of acute pulmonary hypertensive crisis is oxygen. Oxygen is very important. So management principle, provide pediatric advanced life support, administer supplemental oxygen, avoid hypocapnia because it's constricted. So correct metabolic acidosis. You have to avoid hypovolemia, give bolus, and then administer inhaled nitric oxide, which is pulmonary vasodilator, provide analgesic, sedation. Then you can continue with supportive cardiac output and inotropic support. And the other is mechanical support, extracorporeal membrane oxygenation. ECMO is very important. So you can put them on, VV or AV mode ECMO. Severe and refractory pulmonary hypertension. Commonly, those idiopathic pulmonary hypertension, unless treated early, they will go to severe and refractory pulmonary hypertension. They are high risk for mortality, and option of management is commonly surgical. You should do atrial septostomy. Then there will be shunting, so the pressure will be relieved, and as well other procedure like POTS could be done. Mechanical support, ECMO, but if you are sure you are going to do lung transplant, otherwise you shouldn't put a patient on ECMO because they're not going to recover their lung because of pulmonary vascular obstructing disease. So the follow-up, you can follow them, as I have said, 6 to 6 months because response is not easy and more frequent for severe disease after therapeutic changes. You have to take history, physical examination, always almost, and for signs and symptoms of right side heart failure. And if you have to do echocardiography and repeat catheterization 3 to 6 months, or in our setup, you have to do it annually. And additional follow-up tests, you can do BNP, other like 6-minute walk test, and others to rate them the functional WHO classification. You can see the outcome with that one. So long-term health maintenance of a patient as a general medical care is important. So longitudinal care for children with pulmonary hypertension, immunization is mandatory, monitoring of growth parameters, treat respiratory illness. They will have frequent chest infections, so you have to treat that one. And antibiotic prophylaxis for infective endocarditis is relevant. Those with unrepaired cyanotic congenital heart disease, as well those with prosthetic heart valve disease and implanted devices as well. Exercise, sport participation, there could be some restriction, but not all patients. Planning of non-cardiac surgery, so you have to advise. In airplane travel, it should be cautious, and they have to consult pediatric cardiologists before they travel. So prognosis, estimated 5-year survival for pediatric patients with pulmonary arterial hypertension, it's approximately 60-75% with best treatment. But the cause should be familial, idiopathic, and congenital shunt defects. Functional status tends to decline with age, and age is a very important factor. The two most frequent cause of death, progressive RV failure and sudden death, probably secondary to arrhythmia. Arrhythmias are common with RV hypertrophy. So thank you so much. These are my references. You can read them. I will share the slide, and you can see update as well. There are lots of most of the updates on update. It's stated from 2022 and 2023. So you can take a look at that one and use sildenafil, and you can refer patients once you diagnose with pulmonary hypertension. Thank you so much.
Okay, thank you very much, Dr. Eliezer. It was an amazing presentation. So, because we are running a bit out of time, if there's any questions from the participant, we can address one, maximum two questions, and we can end the session here. Is that okay with you?
Okay, I think one of the question that was mentioned here is cor pulmonary. Cor pulmonary, right side heart failure, secondary to lung disease. It's classified here as you can see. Let me share the slide. As you can see here, commonly, lung diseases are classified into group 3. Most of the time you should be selective, but they will benefit sometime. So if you can address the recurrent chest infection, you might improve the outcome. But cor pulmonary could be because of pulmonary tuberculosis, bronchiectasis, and commonly it's adult problem, not pediatrics. In pediatrics, if a patient has pulmonary hypertension related to lung disease, the most common one is in prematurity bronchopulmonary dysplasia. So the benefit for that one, it's well studied. You can use sildenafil, by the way. You can start them as early as 3 months. Did I get the point, please?
Yes, Doc, thank you very much. So, one last question is by Wallace Adik. You can see it, it says, what does it mean? Irreversible left to right shunt lesion? Please elaborate on it.
Okay. Congenital heart diseases with shunt lesion, commonly, let's say ventricular septal defect, which is the most common one, and atrioventricular canal, which is most common in syndromic baby-like Downs. So these patients, they will have flow-related pulmonary hypertension. It's not an actual vascular problem. It's not related with the vessel structural problem. It is related with the volume of blood which is coming from the left ventricle and the right ventricle to the MPA, main pulmonary artery, is receiving left to right shunt volume. So the volume, the mass, when it increases, the pulmonary vessel will increase its pressure. As we said, pressure is equals to mass of the blood times the acceleration of the blood divided by the cross-sectional area of the vessel. So when there is VSD or AVSD, left side blood will come to right side, and the right side, which already received from IVC and SVC from right atrium, will give it to main pulmonary artery. When the main pulmonary artery is overloaded, there will be flow-related pulmonary hypertension. So you cannot give sildenafil or other management unless you address the congenital heart disease. Once you address that one, even if there is mild to moderate pulmonary hypertension, you can start treatment post-operatively. Otherwise, this is what do we mean by shunt lesion. When it comes to irreversible, when there is chronic blood flow to the pulmonary artery, it will remodel. You can see the pathophysiology here, by the way. It's very important. Look at this slide. This is a normal vessel with tunica media externa, and intima. The endothelial layer is good. The media, the smooth muscles, they are well organized and well setted. The adventitia or the externa is well organized and circular. When you come here, there is vasoconstriction, one, because there is low nitric oxide, no vasodilator. Prostaglandin I2 is low, but there is proliferation of endothelial layer. There are multiple, it's not normal like the previous tunica media, you can see it. So it's very crowded and constricted. You understand me, right? So at last, when there is fibrosis and fibroblast regrowth and WBC infiltration to the wall, it will remodel and stiffen. It will be stiff. So blood will not pass easy. It will be resistant. It will have high pressure. High pressure. So it will be irreversible. Once it is remodeled like this, smooth muscle hypertrophy, intimal proliferation, vascular stiffening, then it's not reversible. We call it Eisenmenger physiology. It's no more left to right shunt. It will be right to left shunt. The right side of the blood will be coming to the systemic circulation, to the aorta, or the right ventricle pressure will be suprasystemic. It will be above the systemic. That's very important to understand, by the way.
All right. Thank you very much, Doctor. So on behalf of Blue Hills Ethiopia, Yeni Hills, and all our participants, we would love to thank you for taking the time to present on our platform. We also hope to meet you in future sessions with related topics as well. So if you have any last remarks, let me give you the chance one more time and we can move on to
Thank you so much, everyone. Please come and visit the Heart Center. It's all yours. You can come and join us even for open heart surgery as well as for catheterization. You are most welcome with your friends, with your team, and come and help our kids. Thank you, everyone.
All right. Thank you very much, Doctor. Good night.
Good night.